Welcome. It is Tuesday, September 13th, and this is our September gathering for the West Region Learning Community. We are so happy to have you here. Take this moment to put your name into the chat and mute yourself. And I'll give another welcome in about a minute or so. So just come on in and you're comfortable. We are so happy that you are here today. So welcome. My name is Ty Edward Few. I am with, my pronouns are he, him, his. I'm with the Denver Prevention Training Center. It is Tuesday, September 13th, and we are so happy to have you at this month's West Region Learning Convening. We're going to be talking about injectable PrEP, and I want to turn it over to Dr. Jessica Bloom so she can introduce our presenter.
Thank you, and thanks everyone for being here today. So we have with us today Dr. Hyman Scott. He is a board-certified internal medicine and infectious disease physician, medical director of clinical research at Bridge HIV at San Francisco Department of Public Health, assistant professor at University of California, San Francisco, and chief medical officer at San Francisco AIDS Foundation. I could go on, but we want some time for his presentation. So I'll just add, he currently provides care for patients living with HIV at the San Francisco General Hospital Positive Health Program, and his research and teaching interests are in HIV-related disparities among MSM in the US, with a focus on development and implementation of novel HIV prevention strategies to address these disparities. And without further ado, I'll hand it over to Dr. Scott. Thank you so much for being with us today.
Thank you, Jess. I appreciate the kind introduction. And can you see my slides okay? Great. So I'm excited to talk a little bit about PrEP in a long-acting era. As Jess mentioned, I focused on HIV prevention interventions and really got interested in HIV prevention as a medical student when we would hear about all the disparities that existed in HIV infections and the real, honestly, lack of interventions to both address the disparities and also support HIV prevention. And so since then, we've had approval of oral PrEP with both TDF-FTC and TAF-FTC for MSM. And TDF-FTC more broadly for most populations, including people who inject drugs. And then now we have a new opportunity with long-acting PrEP. And honestly, I think the PrEP rollout, oral PrEP rollout, was a slow walk into supporting HIV prevention. And my hope is that we learned a lesson from that slow walk rollout to be faster with long-acting injectable. And we see the implications of what happens when we don't learn our lessons with this Mpox outbreak and all the lessons that we could have learned from COVID and implemented. So I'm hopeful that we can have a robust discussion about how to increase the pace of rollout for long-acting PrEP so that we don't look back and have missed opportunities and HIV infections that were avoidable. All right, so I don't have any disclosures to report, and the disclaimer at the bottom is for the San Francisco Department of Public Health. I speak for myself, not for them. These are the learning objectives and agenda. We want to review some of the guidelines and well as some resources, and then talk about some of the considerations for improving access to long-acting PrEP in this new era we find ourselves. So the CDC put these guidelines out at the end of 2021 that essentially said that all sexually active adults and adolescents should have a PrEP discussion, and it should be considered as an option. In those guidelines, this is sort of a summary of the different options we have for PrEP. So for daily oral TDF-FTC, essentially anyone except those with pre-existing renal disease, and I would say those at high risk for developing renal disease. And then daily TAF FTC for people who don't have receptive vaginal sex. So that includes cis men, trans women, and people with decreased creatinine clearance. And then we have on-demand PrEP, which has been evaluated mostly in cis men, as well as some trans women. And then we have CAB-LA, which has been evaluated in a broad spectrum of individuals, except those who inject drugs. So we have these great options for HIV prevention now available in the US. So I'm going to go through some of the differences between CAB-LA as well as oral options, but just wanted to give a sort of brief summary of like how this is implemented. We've been a site for HPTN 083 here at Bridge since 2017. So I've had about 5 years experience implementing CAB-LA, which there was a learning curve for sure. So for the initiation visit, it really is about HIV testing with an antibody antigen, as well as a HIV RNA test. Ideally, that's done within a week, and then doing baseline STI testing as well. The big difference between that and oral PrEP is you don't need to do creatinine, Hep B, lipid, or LFT testing. And then the first injection being provided is 600 milligrams IM. There is an oral lead-in that's optional. And so I really recommend that for individuals who are concerned about the injection, and there is no safety concerns based on the clinical trials. So really focusing on it being optional. And I will say that we saw infections occur during the optional lead-in period. I think it is somewhat problematic if someone's having adherence challenges, unless they have a preference for starting with the oral lead-in, to recommend the oral lead-in, because we know that HIV infections do occur during that period. And then there's a loading dose that's given 1 month after that first injection. There are windows around this of about a week preferred. And then it's every 2 months after that. So repeat HIV and RNA testing, site-appropriate STI screening, and then providing the CAB-LA injection. And so that's generally how it's set up. And I think that it is, moving from remote visit structures that are possible with oral PrEP to requiring more frequent in-person visits with injectable PrEP does present a lot of implementation challenges. One of the biggest challenges I think that we've heard about, in addition to the staffing, is testing. So in the prescribing information CDC guidelines, there are some differences. So the FDA actually suggests using a approved or cleared test for acute or primary HIV infection. And that generally, it includes a qualitative HIV RNA. And that is something that is recommended to be done at each visit. CDC says the most sensitive available RNA test. So for example, we don't actually do qualitative HIV RNA testing routinely. We usually do the quantitative, which gives you the number associated with it, or we do a pooled RNA in our health lab. And so those are testing that we do, and we try to do that 1 week before the visit. And actually in follow-up visits, we actually just draw that test at the visit. So we don't require an additional test for somebody to come in. They get their blood drawn prior to their injection, and then we send those off to the lab. So we don't have a rapid test, as some of the trials have done. One of the big things that we don't want to throw out oral PrEP, so we're focused on injectable PrEP, but we also need to let people decide what they want. And there might be reasons why people prefer oral or injectable, but there is actually growing data that when you allow people to choose, they're more likely to stick with that choice. And then leaving the opportunity to discuss the changes in decisions if their life or preferences change later. So for injectable PrEP, we'll see people every 2 months and just checking in with how it's going. Do they want to continue? Is this working for them? I'll talk a little bit about some of the side effects from the injections, but not taking that choice away from our users. And I think now with these different options, we have the ability to approach this more like we do with contraception. And the goal really is to increase the number of people who are on PrEP. And so there's been a lot of concerns about, are we just going to be switching people from oral to injectable PrEP? And I think that that is somebody's choice to make. Then I think that that's something that we shouldn't prevent them from doing. I'm looking at some of the data locally. This is a CROI abstract from last year that looked at what would be the biggest population level impact from the rollout of injectable PrEP. And so if we look at, continuing with our current uptake, we reduced it by about 35%. If we switched folks from oral, a proportion, I think 25% from oral to CAB-LA, we would get some gains, but not much. But if we added 10% of people on oral PrEP, it would increase by, 50% or about 50% for oral or for CAB-LA. And then if we increased by 25%, we would see, proportionally increase in the number of averted HIV diagnoses that we would see. So it really is about expanding and giving people who've chosen not to either start or continue oral PrEP the option for CAB-LA. So not to restrict people switching, but to focus a lot of our efforts on how do we expand the number of PrEP users that we have using this strategy. And so I had mentioned a little bit about the oral lead-in. So these are the safety data for the CAB lead-in versus direct to inject. And so these are the reasons why we did the oral lead-in in the trials, was because there was a concern about adverse events occurring, and you cannot dialyze cabotegravir. So it would, if somebody had an adverse event like hepatotoxicity or something like that, we wouldn't be able to remove the drug. But that didn't occur in the studies. But what did occur is what I had mentioned is we saw some HIV infections that happened during the oral lead-in that might have been prevented if we had gone direct to inject. So when I talk to my patients about it, I say, you have the option for oral lead-in. There's no safety reason to do it. If you prefer, we can absolutely do it. But my recommendation would be to go direct to inject, and then have a discussion about how comfortable people feel with going to the injectable. And we approached this similarly when we moved our participants from 083 from the blinded phase to the open label extension. And we gave people the option to go direct to inject. So 70% of all the participants in the study decided to go direct to inject. 100% of the participants at our site also decided to go direct to inject. So there are a portion of people who will prefer to do the oral lead-in, but just be mindful of the seroconversion risk. Cost is a huge issue, and I'm sure we'll have some discussions about that. So Truvada or TDF-FTC is generic and is $30 or with some 340B pricing. I think it's as little as $4 for a 30 pill bottle. CAB-LA is not that. It's about $3,700 per dose. And coverage varies by state. I know that there's some different states or people from different states on the call. And there are assistance programs, which I outlined here. And then it goes through a specialty pharmacy, or those in private practice can do buy and bill. I think in San Francisco, our experience so far has been that buy and bill, which is the idea that a provider would purchase the drug and then bill the patient's insurance afterwards, after they administer it. That has been a concern for a lot of providers because they're fronting the cost. But that hasn't really been necessary, at least in our local implementation, although we're still really early. Most of the sort of safety net systems, ADAP and Medi-Cal, our implementation of Medicaid do cover it. And so it's actually been quite easier to get it within the public health sector, where we rolled it out much faster than in the private sector.
Dr. Scott, we do have a question in the chat.
Okay.
I believe that Dr. Bloom was answering it, but can you talk a little bit more about what it means to do an oral lead-in?
Yeah, so when we start someone on PrEP, we have an initiation visit. And so during the, and so what we generally do with oral PrEP is we just give them a pill bottle, right? And they take the pills and they just come back and get refills. With injections, sometimes we give them several weeks, up to 5 weeks of pills to see of the medication to see if they have a bad reaction to the medication before we give them an injection, which we, which we can't take out once we give. But if somebody has a bad reaction to pills, you can just stop the pills. And so that was why the oral lead-in was designed for these studies, was because we didn't know at the time whether or not there was going to be a higher risk of people having adverse reactions to taking this particular medication. And so the way that it's now approved is that there's an option to give 5 weeks, so essentially a month worth of pills to someone who decides to take CAB-LA. They would take that for however long they want to take it, and then once they finish, once they decide to start their injections, then they would just stop the pills that day or the day before and receive their injection, and then move forward from there. So that's sort of the oral lead-in. You can see it sort of outlined in this graphic here, where somebody's taking the pills for a purple period, and then they get their first injection. So their initiation visit, first injection visit is actually, pushed out by whatever time they've taken the pills.
Thank you. We have another question.
Yeah.
Do you know if anyone has included CAB-LA in 340B purchasing?
I don't know if that has happened yet. I think I'll have to talk to our city clinic. Last time I talked to them, like last week, they hadn't done any purchasing yet. So I think that there's usually a delay in it being added to the 340B program. So if there are others on the call who've had experience doing this, I'd love to hear that. But we haven't seen that yet here. But we anticipate that it will be added shortly if it's not already.
Thank you, Dr. Scott.
Great. So just a note, this actually comes up because many clinics actually, this is a barrier. So I highlight this not because I want everyone to know how to do a ventrogluteal injection, but that these ventrogluteal injections are a barrier in a lot of clinical sites that require new training and staff to be comfortable to be able to do this. So this is sort of on the side. So the gluteal muscle, which is the butt muscle, sort of wraps around and attaches to the hip. And then on the side, there's fewer blood vessels and nerves to hit. So it's a safer injection location. In our clinic in the Castro, this is actually where we do all of our injections, including for ceftriaxone and bicillin. So it's a safer injection, but it does require positioning and comfort that many clinics actually find is a barrier when they start trying to implement this. So making sure the clinical staff feel comfortable with it is an important element of implementation. And then I'm just going to talk a little bit about the injection site reactions. So they are common. Unlike, oftentimes with bicillin, people, it hurts right away. This usually doesn't hurt until a day or so later, and it usually lasts a few days after that. It's very common. So it's so common to the point where I tell my patients, you're probably going to have an injection site reaction. It's going to happen tomorrow, most likely. It's going to last a couple of days, and it'll get better over time. So we don't want folks surprised when they develop a injection site reaction, which is mostly pain, and then think that it's something very abnormal. It's very common, and as you can see from this graph, it gets better over time. It's usually not severe, and rarely leads to someone discontinuing. So I'm going to skip through this because I want to make sure that we have some time, but I'm happy to talk through any injection site reaction management questions, because this is really common. The other question we get is around how do you manage missed visits? And so currently, this is what the FDA label says. I actually think that this is not necessarily, this is going to be difficult to implement because it's so strict without putting people at risk for HIV acquisition. So 0 and 4, so 0 at initiation 1 month, and then every 8 weeks after that, or every 2 months. Generally, the goal is within a week of the target date, either before or after, giving people some room. They recommend an FDA, if somebody is more than a week late, to bridge with oral CAB, and then switch to TDF FTC or TAF FTC if it's longer than that, and then reassess if it's if somebody is appropriate to receive it, and then restart CAB LA as soon as possible. And then they break this up into planned and unplanned. And if it's more than 4 weeks, then they recommend reloading. So what we're doing is something a little simpler. And so the goal is the same. Initiation 1 month, and then every 2 months, same goal. We want to try to get the injection target within a week. I will say in the clinical trials, it was much more lenient, and it still was highly efficacious. And then we're actually recommending provide TDF-FTC to cover gaps, not CAB LA, or not oral CAB unless you have it easily available. And then just counseling patients. So I give a prescription at their initiation visit, and say, this is in case you miss your injection visit, because I want you to be protected. And then if it's less than 4 weeks, they can take it for however long they need. And then we restart a CAB if it's less than 4 weeks. If it's more than 4 weeks, doesn't matter if it was planned or not. We reload them, and they come back every 8 weeks. So trying to make it simpler for patients so that this is not a high barrier for them to feel like they're doing what they need to do to stay protected. And this is based in the clinical trial experience. So without harming, interfering with patient safety. And if somebody decides to stop CAB LA, really talking about the tail, that this will last in their system for a year plus, that we really want them to stay protected if they need ongoing HIV prevention with daily TAF FTC or TDF FTC. And then important is to remember that quarterly RNA testing is actually recommended for the year after, given this long tail. So just because someone stops CAB LA doesn't mean that they stop RNA testing, that's recommended for 12 months after discontinuing. So are there any questions about any of that part? I wanted to move into talking about some implementation.
There are no questions in the chat, Dr. Scott, but if you do have a question that has not been asked or answered, you can either type it into the chat or unmute yourself and ask Dr. Scott. So I think you can go on to equitable implementation challenges, because I know there are going to be some questions there, especially.
Okay.
So thank you.
All right. I show this slide because I really want us to not forget all the things, as I mentioned in the beginning, that we learned from oral PrEP. Many of these things apply to injectable PrEP, and we still haven't addressed them. So I think it's we need to be realistic and transparent about what we still need to do. So both provider and patient education, we're doing the National HIV Behavioral Surveillance, and we still have only about 50% of our people who inject drugs who know about PrEP. And so we need to really ensure that our community members know about this tool so they can make a decision. And talking about how you have these conversations about PrEP without stigmatizing PrEP users, without talking about it in high risk language, and talking about it in a way that is sex positive and supportive. Talking about risk perception, and I think that the new CDC guidelines make this simpler, like everyone should have an education about PrEP, and if they want it, they should get it. And then a conversation about ongoing needs for PrEP. Talking about how we discuss sex and not stigmatizing individuals. We're getting a lot of sort of attention with this Mpox outbreak, and being transparent and clear about what biases exist within our health systems and how racism is impacting our ability to address these disparities that we have. The access isn't universal, that we need to address social determinants of health. We're seeing a large increase among people experiencing homelessness in our communities here. And I know that that's something that's occurring nationally. And then how we are approaching benefits navigation and the sort of offsetting the costs. And then also letting people know about the side effects that can occur so that they can be not surprised. And I think it feeds into some of the medical mistrust where things are happening that people are sort of unaware and have been not prompted about. And I think there's a concern that it would undermine our ability to somebody's interest in an intervention, but I actually think it runs the opposite. I think that people leave our system and then don't trust us enough to come back.
Correct. Dr. Scott, we do have a couple of questions. Going back to your slide, if you could roll back one. What has community involvement / engagement look like to address stigma and misconceptions?
So I think it looks like a variety of things. One is I think it's involving the community, having a perspective, not creating sort of educational campaigns and approaches that are siloed away and that it's unidirectional, and they're like really involving the community. So we've had missteps, of course, and I think many places have, where, you know, starting with a community sort of based good clinical practices where you involve stakeholder discussion, you sort of highlight what the community will be responsive to. And particularly if you have representation of the community within the sort of either health system or DPH system, then, you know, honestly, just not being out of touch. And that's how we create these programs and these campaigns. You know, I think the Chicago campaign is a prime example of that. I think New York has done great campaigns. LA has done great campaigns. And then we've done some, what I think some fabulous campaigns here in San Francisco, although I'm probably a little biased. But I think that that's what it looks like. It looks like a slower process because you need to engage community and then put it out into places where people are. So, you know, on transit, on apps, in bus stops, in places where people are, so that they can see it.
Awesome. Are there any tips for possible strategies for rural communities when talking about some of these barriers?
Yeah, so I think that within the rural communities, I think that there are a variety of issues that come up. One is you'll have probably fewer providers that'll be further apart, so it'll be more difficult to do any centralized type of education if people are sort of physically and distant from each other. So I think that it might require more of what honestly the pharmaceuticals do. So provider detailing, so having people go into those communities, doing some education with providers. Outreach might need to happen in a different way. So using locations where people are connecting, or whether they're virtual venues or physical venues, to support sort of reaching community members. And then thinking about ways to close the distance. And one of those is home-based strategies. And so using home-based strategies for both testing and for implementation. I think with injectable PrEP, it creates new challenges because you'd eventually have to go to somebody's home to provide that to them, but that might be what's needed. So I think really thinking about what is what is it in your community that's going to allow this to happen? And that, the model that happens in a city is probably not going to be directly translatable to rural communities. So I think thinking more about honestly, we can learn a lot of lessons from how things are implemented in sub-Saharan Africa. They have similar challenges with distance, and particularly in rural areas, that they've overcome by sort of having a more decentralized system to provide those services. And it includes more outreach into those communities by health workers, by providers. And that's really the strategy that I think would be needed in the US.
Thank you. And so we had really good encouragement for us to do provider detailing, which is great. Also, just really think about advancing community health workers, which has worked all over sub-Saharan Africa. The questions are now rolling in, Dr. Scott. We just needed a couple and now we're on fire.
Okay.
Another question is talking about any thoughts about pharmacy implemented CAB LA.
I actually think pharmacy implemented CAB LA would probably be easier than oral PrEP, because you don't have to do all those safety labs. Like, you don't have to monitor creatinine, you don't have to monitor lipids, which, I think is questionable whether or not that needs to be done. You don't need to monitor LFTs either. And so the main thing is the injections, and making sure that the providers are able to do that, and then being able to do the labs, so to do the viral load labs. So 100%, I think that we don't have capacity to roll it out in the ways that we need this rolled out to make a difference in the pandemic that we're dealing with. So we need pharmacy implementation. We need decentralized care structures to make this, to not make this a slow walk like we did with oral PrEP, but to actually speed up the implementation. And we did this with COVID, right? Pharmacies are now set up in ways to administer vaccines in their pharmacies, and we need policies to support it. So I think California is an example of a policy where we now have a way for pharmacists to initiate PrEP. We need more aggressive policies to both allow them to manage and ongoing. Kaiser's PrEP program is essentially run by the pharmacists. So there's no reason that we can't do this in a more expansive way.
So more admonitions for us to get that PrEP in pharmacies out there. It's also a way people trust pharmacists in some of these rural and frontier communities in a way that they don't trust other medical professionals. So thank you for that. That's all the questions we have for right now, Dr. Scott. You can keep on with your presentation and we'll chime in later.
Okay, sounds good. So I just wanted to go through some of the ways that I think about these different options. And I know we're talking about CAB LA, but we can't ignore the fact that we have a very powerful tool as well for HIV prevention. And there's some pros and cons of both. So I think the pros for oral regimens is that you have daily and on-demand options for people, that you can have flexibility in implementation. During COVID, we essentially didn't do any in-person visits for our PrEP users, refilled their prescriptions, had them come in for labs, and minimized time in clinic. We couldn't do that with CAB LA. That we have data on all the populations for oral PrEP. It only requires quarterly HIV antibody antigen testing. It's generic and it's very cheap, but it's daily adherence or a complex regimen that sometimes people struggle with, and then having pills around might not always be acceptable for all people at all times. So it's a barrier. And I think for CAB LA, it's superior in the clinical trials. And I think that there's a lot of question about what drove that superiority, and that, of course, it was driven by differential adherence to oral PrEP compared to receiving an injection. But that's always the case. Like that's the explanation, but it doesn't change the result. And that we saw that this was higher protective for preventing HIV infections compared to oral regimen. Allows discretion. There's no daily adherence requirements, but it does put more burden on the health system. So more visits, more testing, higher costs. And then unlike oral PrEP, interestingly enough, we've seen this resistance occur in breakthrough infections, even among people who received on-time injections, in a way that we didn't see with the oral regimens, that really was failures were driven by different lower adherence. And so I think that we're still trying to understand why that happened, but it is something that it's important to talk to people about, and doesn't change the recommendation that this still works really well, and prevented a lot of other infections, but it's something that we shouldn't just ignore. And then there's some clinical considerations, HIV testing and availability. Not all places have rapid testing. Doing viral load is quite expensive, and not every place has access. Even in San Francisco, some of our primary care clinics struggle with doing viral load testing because of the transportation requirements and handling. That the visits are going to be more burdensome for the clinic, requiring more staff and labs. Same-day starts will be more challenging in most places. And then how do we manage missed injections? How do we manage delayed injections? I think there'll need to be more proactive outreach for many of our folks who've been on oral regimens, right? They get a refill, they have a 3-month supply, they can get a refill, 2 to 3 weeks before that expires. So they often have extra pill bottles. So if they miss a visit, they can continue taking it if they have extra pill bottles. That's not going to be the case for, missed injections. And so there might be more proactive needs to follow, which is another reason I think to involve strongly with pharmacists in this management. And then how do we manage post-exposure prophylaxis if somebody has exposures? So we have a lot still to learn for the implementation of this.
And Dr. Scott,
okay.
we have a question about PrEP.
Okay.
So have there been any studies using injectable as PrEP?
No. Okay. There's some studies that are looking at PK. Let me take a step back. There are very few studies actually looking at oral ARVs as post-exposure prophylaxis in a non-occupational setting. So just for reference, we're basing our current guidance on, not on clinical trial data. So we haven't moved into that with injectables yet because they're just coming out. But I do think that they will have a role. And I know that lenacapavir, which is another long-acting injectable, we're not talking about today because it's in clinical trials, is also being considered for post-exposure prophylaxis. So I think that there is a role for injectables. I don't know that we're ready for CAB right now.
Thank you.
Great. So I talked a little bit about this, the breakthrough infections. And so, it is something that we are very mindful of, and that, the delay in HIV diagnosis is about 90 days if you compare just using a sort of antibody antigen test to a viral load test. And like, how do you manage that? We have conferences actually in one of our clinics that sort of discuss the discordant HIV test results and how do you manage it. So it'll be even more complicated with injectable PrEP. So this is what I was mentioning. So, receiving a CAB injectable, delays ability to diagnose HIV by quite a 2 to 3 months on average, and that's why the RNA testing is recommended. I talked a little bit about this washout, and the thing I want to highlight on this is that there are some sex differences. So in the top panel are individuals who are assigned male at birth, and at the bottom are individuals who are assigned female at birth, and that you can see that for the participants who were assigned male at birth, that it was detectable on average out to 10 months. But for those who were female assigned sex at birth, we're talking 16 months. So and some people it goes out to like, 2 years. So this can be in the body for a long time, not that it's causing problems for adverse events, but if somebody were to have ongoing risk and acquire HIV, there's probably sufficient amount to cause resistance and not provide protection. So it is something that is really important to sort of describe and explain to patients that they're aware of it. These are just some system considerations. I need to update this slide. There's actually no cold chain. This is stable at room temperature. I know that some clinics use refrigeration so that they can maintain within the sort of 30 degrees, particularly if you live in an area where there are large extremes in temperature. With our heat wave in California, we actually had trouble in our lab maintaining the sort of ambient temperature. And then talking about on-site storage and pharmacy delivery, it's been a implementation challenge to overcome, as not all the pharmacies carry it. And then how you set up your rooms so that you have the ability to do the injections. And then there are some local regulations for who can administer them. And then it's providing some navigation and visit adherence support tools. Patient navigation, I think, will be even more important to CAB LA because of the likely need for more reminders for the more frequent visits, and also supporting the cost, as this is going to be a much more expensive intervention than our oral regimens currently. Speaking of cost, this is a cost analysis that was done that looked at what was the cost of CAB LA in yellow at the top, compared with branded FTAF, compared with generic FTDF, compared with no PrEP. So generic FTDF is cost saving compared to no PrEP, but that both TAF and CAB LA are not. And that it would need to be reduced substantially in the cost per dose in order for it to be either cost neutral or cost saving compared to no PrEP. But there are some programs that are available to help cover the patient costs, even though the sort of insurance societal costs will be much higher compared with our oral regimens. Just a couple of policies I had mentioned, the California pharmacy policy, but there's also the PrEP app program. And I will say that in California, at least, the Insurance Commission has come out and stated explicitly that they view injectable CAB LA in the same way that they do oral PrEP, which has a U.S. Preventive Service Task Force grade A recommendation and is required to be covered at no cost by insurers. And so we're trying to evaluate how much adherence there is to that guidance, so that it's clear that this should be covered without cost to patients, and then how much of this is going to be limited through processes like prior authorizations and those kinds of things that we know limit access. And then the California SB 159, I think we have seen variable rollout of this. I think in San Francisco, we have some support among our pharmacists, but I think that it hasn't been really utilized in the way that we've hoped it would be. So I think that's where I will end, and just wanted to acknowledge a lot of our colleagues that have helped us with this work. And at the bottom is actually one of our ads that we did for our injectable PrEP that was on buses, as you can imagine, that were sort of circling the city, and got quite a bit of attention. Mostly good, but some people had some other thoughts about it. But this was an example of a sort of a education ad campaign that we did that was focused on injectable PrEP. So I'm happy to answer any questions that folks have, and would love to have a discussion about how we can increase injectable PrEP in our communities.
Thank you so much, Dr. Scott, for that really rich discussion. I already see a comment in the chat. My understanding is that efficacy of long-acting injectable PrEP has been demonstrated among people who inject drugs, but general uptake has not been documented. Are there drug user health programs you're aware of that are using long-acting PrEP?
So long-acting PrEP has not been demonstrated among people who inject drugs. In fact, if somebody had HIV risk from injection drug use in, for example, HB10-083, which was one of the studies that was used, they were excluded from that study. And so general uptake of PrEP overall has been quite low. So, for example, I think in our data here, about 3% of people who inject drugs used PrEP in the last 12 months, and only about 50% were even aware of PrEP. So it's been, I think, universally pretty poor. I think most of the large PrEP clinics don't have many people who inject drugs in them. And in our primary care clinics in the San Francisco Health Network, we did have a small proportion of individuals who injected drugs, and persistence or continuation was actually quite low among that population. So there needs to be more integration into these syringe services programs and clinics. And I think we need more representation, going back to the community representation, about how we provide this education that this is an option for people who inject drugs. It's not just for men who have sex with men, which I think has been the general messaging that has percolated both in the community, but it's also been part of the focus of our ads. And so I think that that's a huge gap that we have.
Thank you. And just going back to some of these discussion questions, can anyone share, are there organizations in your jurisdiction that are offering injectable PrEP, or are there organizations that want to offer injectable PrEP but are facing specific barriers?
Is that directed at me, Tess? Or is it more broad question?
It's a broader question, but actually, if you're aware of organizations that want to offer injectable PrEP and are facing barriers, that would be great to share.
Yeah, I think that there's been so we have several places in San Francisco that are offering it, but that's just sort of starting now. I think the biggest challenge has been staff and space. And also figuring out how we're going to do the navigation pieces for this, because now many of these places have been doing, these are the places that have been doing oral PrEP for many years, and that's sort of on autopilot in many ways. Even though there's large numbers of people, the systems are clear about how to get access. They're not so clear for injectable PrEP, or haven't been, and there have been some updates, including like ICD-9 codes, pharmacy coverage, and those kinds of things that are just sort of happening over the summer. I believe July was when they were implemented. And so we're just sort of trying to work our way through it. And then many of these places are also dealing with Mpox. So, that has sort of taken priority. So I think that's been a variety of challenges we've experienced here. I'd be really interested to hear what others have experienced, or even if these conversations are happening, like what are the barriers to even like talking about this as an option to provide.
Oh, we have another question from Maggie Esquivel. Can you share details on providing PrEP injections in the field for vulnerable populations? And have you provided PrEP among sex worker populations?
So we haven't done PrEP in the field. I will say that, there is no reason that we couldn't do, say, an injection like this, as long as you have the space to be able to do it privately, in either like a mobile van or in a sort of field like treatment center where you have the privacy to be able to do this. We do, sexual health swabs in the field and in bars. So like we can create the space so that people can receive these injections in the field. And I think, among sex work populations, it'll be important, particularly if there is a, geographic sort of preference for where you would provide these. Because I do think, particularly for populations that are at higher risk for acquiring HIV, who are not, for whom our current health systems don't meet their needs, we're going to have to move outside of what we usually do in our usual business to be able to provide those access. And we had a lot of funding with COVID to be able to do that, and it seems like that's probably what we'll need to be able to move our HIV prevention towards our EHA goals. But there are going to be folks who are just not going to come to clinic, and they're not going to come back to clinic if they come the first time often. So how do we support people in places where they want to receive services? And that is inclusive of, I think, rural areas as well, where you don't have places. And also, I go back to the stigma thing as well, because even if the providers, like the medical providers for whom we focus a lot of our attention, are not stigmatizing, that doesn't mean that there are not other staff in the clinic who are causing that issue. So we've definitely heard, even during MPOX, that people are stigmatized in places where we didn't think that would happen to them by staff, by front desk staff. We still struggle with this with oral PrEP. We have to think holistically about what the patients are experiencing, and it's not just they're not just interacting with the clinicians. There's lots of other people that they have. So decentralizing this is harder for us, but it's easier for them. Then we need to think about that balance.
Thank you. And I see another question. Do you have a preferred schedule for testing? With injections every 2 months, do you test patients for STIs each time? Have them come in every 3 months in addition to the injections?
So we, our approach has been, we offer testing at every visit and recommend it at every other visit. So it's every 4 months is when we expect people to get tested. And then, we offer it every 2 months. So people can go decide what schedule they're on, depending on what might be happening in their sex life. And so they can get tested more frequently. But no, we don't ask them to come in for an additional visit. We don't want to make this any harder for them than it already is. They can always come in if they want, and then do that. So there's a question about insurance covering STI testing. So we've been doing this primarily within our public health and safety net. And so I think we haven't run into that issue of insurance covering STI frequency. I'd be interested to hear if other folks have experienced that. We haven't heard that from our private practice providers either, some of whom do STI testing monthly for some of their patients who have an indication to receive that, and they haven't had issues with that.
Thank you. And I saw a couple folks had commented on insurance issues. I don't know if anyone wants to speak on that, what they're hearing in their community about barriers with insurance. But I guess one question I could ask you, Dr. Scott, is this issue of pharmacy versus medical benefit, and you mentioned buy and bill. Those are some of the nitty-gritty things that I think seem like high enough barriers that some folks are sort of waiting to start offering injectable PrEP.
Yeah, and so I think at least our local experience in California has been that it's mostly a pharmacy benefit, and so that's made it more streamlined to be able to fulfill and access, and that it's not being determined to be a medical benefit in most of the private practice that have been implementing it. Within the public health sector, it's been, covered by Medicaid and, relatively easy to access. And we haven't had this experience yet within the private sector of a medical benefit, which would require, a procedure, which would be the access and the injection in a way that is problematic. I think some of the insurances actually have moved some of our STI treatments to a medical benefit. So it requires people bringing in their prescription ceftriaxone or even Bicillin to be administered. So, I think that it'll depend on the jurisdiction and what the insurance requirements are and what the insurance providers are. But, it's another layer for sure compared with oral PrEP, which was, clearly a pharmacy benefit.
Yeah, and I guess just to add on that, have you had any experience in working with the manufacturer around the assistance programs? We've heard some challenges with that it hasn't been as straightforward as it had in the past, and trying to work through some of the assistance programs.
Yeah, I've definitely heard people having some issues with that. We have been trying to work closely with our representatives from ViiV Healthcare to try to escalate things and to identify a point person who can help us navigate through that system. And so I think that that's been really helpful. So I'd recommend if you have, a regional representative from ViiV Healthcare who can help with some of the streamlining of this process, that's been helpful locally with some of our groups. I don't know if there's folks, I see a few folks from San Francisco on the line, if they have experience that they want to share.
I wanted to add, Robert Moya put in the chat, is anyone having issues where insurance just does not cover it and oral is the only option? Robert, I don't know if you want to come off mute and provide some background to that. Have there been examples in your community where that's coming up?
Hi, this is John Murphy. I'm with Robert. I was the one who actually asked the question.
Oh, thanks, John.
No, I was just looking up as a state employee, I was looking at our insurance plan, and we are currently on CVS Caremark. And I looked it up just to see what would it cost for us to do it. And it just said it's not covered. And basically we would have to go with the oral PrEP. And so I was just wondering if anyone else is running into that issue.
Here
Yeah.
in Nevada. Oh,
Go ahead, Preston.
can you guys hear me?
Yes, we can hear you.
Okay, my microphone's been doing something weird. Yeah, I feel like a lot of insurances are not covering it as of yet. Hopefully by the end of this year, it'll be starting more coverage in 2022. I feel like same thing with my insurance as well. They would not cover the injectable PrEP. They'll only cover oral PrEP for now because it was really so late last year. I think it was December 20th, if I recall correctly, that it was approved and by FDA. So yeah, it wasn't on the insurance plan yet to be covered. And so I'm waiting to see if it gets approved starting in 2023.
Thank you for sharing that.
I was just saying a lot of our organizations here in New Mexico are waiting on whether or not to use it, just because we can't figure out whether it's billed as a pharmaceutical visit, whether it's billed as a medical visit, and whether insurance are even going to cover it. So I don't think anybody here in New Mexico is offering it currently.
Yeah. Yeah, and even if it's a pharmacy benefit, if it's a specialty pharmacy, that generally takes 6 to 9 months for it to make it onto those formularies. And so there's been a lot of consolidation of pharmacy benefits. And so I think July was when that was supposed to start happening at the insurance level. So I think that that's been an ongoing process and been a definitely an implementation barrier. And I'm not sure New Mexico is, has the same approach towards coverage of PrEP and sort of the implementation. I think in California that the policy has been more sort of aggressive and in terms of pushing insurers to sort of add this to their programs. So it's not universal. And I think in private practice, as I said, we've had a much lower uptake, partly because of these insurance aspects that folks are highlighting.
Is Medicaid covering long-acting injectable PrEP in Nevada or New Mexico or any other folks who are present here? If anyone can care to comment on that.
Not currently in New Mexico. Everything's kind of being pushed a little bit more towards generic at the moment.
That can certainly be a barrier. I think that discussion with the California Health Commission requiring it to be covered was helpful because as folks are aware, the U.S. Preventive Service Task Force requirement that PrEP be covered didn't specify anything about injectable PrEP since it occurred in 2019. So that could certainly be a barrier.
And, I think that this is also an opportunity focused on community engagement and working with the community advocacy groups within your community to demand that this change. A lot of the things that changed around PrEP access actually came from community response to this. And so I think that we've been also trying to leverage that advocacy to move these institutions to be more responsive to what we need for this. So, I think that's a partnership that we have an opportunity to build and to strengthen where it already exists around this issue. And if that's successful, though, then we need to be ready to be able to offer it. So thinking about, not just one single approach, but how do we engage our community, both for education and advocacy, and then engage our provider base to be able to offer this in a way that we would like to, if it's something that somebody desires.
And I think that's a great point in terms of considering engaging communities of color with PrEP. One of the discussion questions was about, what are lessons learned from oral PrEP and how can we apply them with injectable PrEP? And I think you made a lot of great points in your discussion earlier. I think this payment piece plays into that. As many folks are bringing up that, if insurance is not covering it, it won't be accessible across the board, including for communities who most are in need of effective prevention. Are folks from California DPH here? And has anyone been involved in that discussion around Medicaid coverage and PrEP AP or PrEP AP coverage of injectable PrEP?
I don't see anyone from UCSF here, but I do know that in California, Medicaid covers it without question. Actually, we get it same day if somebody has got Medicaid.
Wow.
And so, yeah, in many ways, our public systems are, ahead of private settings in ability to provide this. So I think we probably have the largest number of people on injectable PrEP in our public health clinics for that reason.
That's the irony, right? That the biggest barrier is coverage at this point.
Yeah.
Have you seen other barriers beyond coverage, since Medicaid is not so much of an issue in San Francisco?
I think it's, it's education. I think a lot of people just aren't aware of it. There hasn't been the same level of discussion about it. It's not something that, when oral PrEP first started, right, we had providers who were, providing sort of sexual health services within the community who knew about it and were talking to their patients about it, and they were starting them on it. And then it changed, right? It changed from, providers, talking to their patients to patients coming in and asking for it. And then in a very uniquely San Francisco way, in many ways, people started coming in wanting it because, they were saying they couldn't have sex because they weren't on PrEP. And that there became this society, this community normative sort of behavior in many ways around being on PrEP. And like, we haven't had that happen yet for injectable PrEP. So there hasn't been the community demand yet. And I think we also don't have the supply. So the fact that there's not a huge mismatch, but, all the patients that I've talked to, save one, about it, wanted to, to use it because they didn't want to take pills every day, many of whom had difficulties with adherence. So yeah, I just don't think that there's a community discussion about it because of the issues we're talking about today. It's just not freely available for many people. And so I think hopefully, my hope is that, that we're talking about maybe a year and a half where we can get to a level where people know about it and can access it, not 5 to 7 to 10 years like we're dealing with oral PrEP, where we still have 50% of people who inject drugs who've never heard of something that's been approved for a decade.
So what should organizations be doing in the next year to start to sort of be looking ahead to that moment when it's more widely covered?
So I think that there's a couple of things. I think that, we can have an inclusive approach towards thinking about the different options for PrEP as we, as you do education or you do campaigns about it. I think that there's somewhat of a fear of like creating a demand that you can't meet. But I actually don't think that that's worse. I think that that's worse than, not worse than having a supply and no one being aware of it. And that's been our approach to Mpox vaccines. We knew that we had less supply than we had interest, but we needed to ensure that the community were aware of it so that they could, so when we did have it, that we could roll it out very quickly. So I think creating messaging that's inclusive of the options, sort of having conversations with providers around offering it in such a way. So at one of our sexual health clinics, we have this sort of shared decision-making approach towards PrEP. If you come in for PrEP, these are the, for MSM in particular, these are the 4 options you have, the 2 daily options, the on-demand option, injectable option, and like which one works best for you, and then starting the conversation there, so that when we do have it available, we can offer it and help people stay on it. Persistence is terrible for PrEP. The majority of people who start do not continue it for a year, and we have seen small declines overall in our HIV infections, more so in places where we have larger PrEP uptake. But PrEP persistence, at a year is, as low as 40 to 50%. So we still have a long way to go for PrEP.
Thank you so much for all of your thoughts and experience and wisdom. I think we can wrap up for today, but I wanted to give a chance for any last questions or comments that folks have been holding on to. And really appreciate if folks can go into the chat and answer the evaluation. Your evaluation results are how we can keep offering this learning collaborative. So we really appreciate your feedback, and wanted to give a special thank you to Dr. Scott for being here today.
Thank you so much for inviting me. Hopefully if we have another discussion in a year, it'll be a, what you're encountering as you implement injectable PrEP.
Wonderful.
Yes, thank you, Dr. Scott, so much for coming. One quick announcement, colleagues, due to USCHA happening a month away, we're going to be moving our West Region Learning Community to Tuesday, October 18th. So Tuesday, October 18th will be our next session, and we are excited to see most of you in person next month in Puerto Rico, attending sessions and coming to our booth in the Convention Center Hall. Thank you. Have a great day.